Off. Hi, everybody. This is Alex projecting to you live from our CHCANYS headquarters in Manhattan. Today is November 1st, and that means that we're going to focus on our webinar part 4 in the series of 4 webinars on CMS Emergency Preparedness Final Rule. We are going to be looking at what has happened with the rule because it's been more than a year already, and we are going to look at any relevant updates that may matter to you. So let's go ahead and kick off. We are using Zoom, and that means that you guys have access to the Q&A module. You can utilize that module. You can raise your hand, you can use the chat, and by now you're probably more than used to this new platform, which we really like, and we hope that it makes the things much easier for you as listeners on this webinar. You are muted for the duration of the webinar, so please don't hesitate to use the chat feature if you want to submit any of the questions or interact with me in any way. We are using the video. I hope it's projecting well. And let's kick off our content. So this is us, your emergency management team here at CHCANYS, Community Healthcare Association of New York State. Thank you to all those who attended our EM breakfast at the CHCANYS conference in October. Well, we are in November, but it seems like an eternity away already. Gianna and Michael are here with me in spirit, and they are helping with certain activities. So this is us. Just a reminder, we are your primary care association. That means that we can provide you with training, technical assistance in these areas that you see on your screen, but not only. There's advocacy as well. That is based in our Albany office. So please don't hesitate to reach out to us with any questions, concerns that you may have. You probably already know that emergency preparedness program sits under the health center support, and our fearless leader, Suzanne Rossell, is the supervisor of that program and the department. We are at the end of our series. It's been a month-long series. We have looked already at the overview. We looked at the 3 required elements of the rule already. That is planning and policies and procedures, risk and assessment, training and testing. So today we will be looking at communications and integrated systems. We're going to be looking at any relevant updates that may be of use to you guys, people who are implementing and operationalizing this whole rule as it comes to FQHCs. So what are we trying to do today? These are our objectives. So we want to look at the communications, the requirements and the rule, what that means to you guys. We will also look at this strategies, some strategies that you should consider trying to implement communications and integrated health systems. And also I wanted to provide you with relevant updates and resources. The webinar is scheduled to go for an hour and a half, although I'm not sure we will use all of this time, so I may let you out early. So again, the rule introduced an additional element in the FQHC's conditions for coverage, that is 42 Code of Federal Regulations 491. There were 11 paragraphs that you needed to meet as conditions for coverage for FQHCs and rural health centers in this case. And the CMS rule introduced paragraph 12, which is emergency preparedness, and it described in detail what that meant for you as FQHCs. Now, again, based on this new introduction, well, it's not new anymore, CMS rule introduced the requirement to have the emergency preparedness program. We are looking at 2 elements. One of the elements is a required element. It's listed under letter C in the rule, which is communications plan. And the integrated health systems is an optional element. You're not required to implement this element, but it is an option for you if you have multiple locations and you'd like to have these locations integrated into a program that is unified. So that's built under letter E in the rule for 191.12E is the Emergency Integrated Health System. So we're going to kick off with an update on the new proposed CMS rule. If you've been following this webinar series and our EM session at the conference, you probably remember that I have been talking a lot about the new proposed rule that has been in the works. So it was introduced on September 20th. Of this year, and we are currently in the comments period, which is lasting until November 19th. So just a quick summary, this rule would lessen the burden on the requirements that you will see in a second of the current CMS rule regulations. So it will make the review process a little bit less stringent. Instead of every year, your review would be every 2 years. And it would lessen the amount of exercises that you need to do. Instead of 2, you would need to do only 1 exercise per year. Now, as you probably remember last time, I gave you an update on the upcoming webinars. So one webinar hosted by CMS already has taken place. That was this Monday. And there's another one upcoming on November 8th. I listened in on the webinar on October 29th. There wasn't any groundbreaking information that they introduced, other than they answered the question that I posed. And the question was, how likely is it that the rule gets implemented, and if it is implemented, when do they feel it will be kicking in as a final rule? Considering that the rule itself is not controversial and there's really there shouldn't be any opposition to what the rule is proposing, it will make the life easier for a lot of people. So the guy who works for CMS, doctor, I don't remember his name, he responded that we are absolutely right. The rule is not controversial. They are in the collecting of the comments period, which you remember ends on November 19th, right? So they have to collect all of the comments because it's a rulemaking official process. And then they must respond to each comment that they received. It will only then, after they respond and address each comment that they have received, the rule will likely become final. So what I got out of that is that it's not a matter of if the rule gets finalized, but when. So stay tuned. More likely than not, this rule will become final in the coming months, sometime in 2019 from what we expect. But you do have an opportunity to log in by yourselves on November 8th. In the slides that you'll receive in the PDF, you can just click on the link to register. So that's an update for you on the Omnibus on Burden Reductions proposed rule that is currently cooking, so to say, with CMS. Again, a reminder that all of you should have a copy of the CHCANYS developed emergency management plan template. It is available by request. I think looking at the list of attendees, you guys all have this template. Just a note, it has been updated in this year. The updates are not necessarily all that groundbreaking again. If you have the previous version, it's not that much different from this one. The main change is that the integrated health system language we introduced in the update. And also this template will be released nationwide through our partnership with the National Nursing-Led Care Consortium, which is the National Cooperative Agreement holder entity under HRSA. And that template will become, in the new version, will become available to FQHCs across the country. So you guys already have this, but let me know if you're interested to see the updated version. And the reason why we bring up this template is because communications is a section in the template itself. So under the current proposed template that we have for the emergency plan for your organizations, communications sit under section 5. This is a section where you would describe your procedures, your risk communications, your partnerships, your contact lists, and everything that's required by CMS. Now, one comment to make here, this structure with this section 5 assumes that you have an integrated plan. That is, that your communication policies and procedures are integrated within one plan structure, right? So you have one emergency management plan, and that includes all of the policies and procedures under communications. You may choose to have a separate plan that CMS wants you to have, and we'll see the requirements in a second, but CMS wants you to have a written communication plan, which may actually make your life easier if you separate it into a separate written document. That way you can just produce it separately from your integrated emergency management plan that you see on your screen, because it's much easier to provide a separate document than then just refer people into a section that contains everything. And if that's your approach to having communications policies, then in this section, under this structure, you would just basically mention them without any details and refer the reviewers, the users of the template, to the separate plan that you will be then attaching as an annex to your general document. Now, let's talk about communications plan and what's required. This is the quotation from the rule itself, regulatory language. So you as an FQHC must develop and maintain an emergency preparedness communication plan that is reviewed and updated annually. Again, this is the current requirement. The rule that's proposed that's augmenting the frequency is not final yet. So keep an eye on that. You are required to update and review the communications plan and all other elements actually annually as of today. If that changes, we will let everybody know. So your communications plan must have the following elements. You need to have names and contact information for staff, entities providing services under arrangement, your contractors, whoever provides services to you as an FQHC, but are not staff necessarily, patients, physicians, if you have locum tenens involved or somebody under contract, that must be in there, other rural health centers and FQHCs. Consider them your neighbors, and they may be similar or neighboring service area, your volunteers. These are the entities that are named by CMS as required pieces of information that you must have in your plans. Additionally, you must have contact information for federal, state, tribal, regional, and local emergency preparedness staff. This is as much as they give you. They don't tell you, well, you must have New York City Emergency Management or your local public health department. So you have certain discretion of who that list should consist of and what entities should be part of that list. And as paragraph 2, they say other sources of assistance. So you as an FQHC, as an organization, have a certain discretion level of what that list should consist of. So think of anybody and everybody who you may use in case of emergencies, because this plan will address your emergency communications. And a little bit more about that later. So we will talk about who you should consider for this list. Third, primary and alternate means of communicating with your staff and those entities that you have identified earlier: federal, state, tribal, regional, local emergency management agencies. So it's important that you have primary way of communicating with these entities and the staff and patients, and secondary in case the first primary mean of communication fails you, so you have backup. Fourth, a means of providing information about general condition and location of patients under your facility's care, as permitted by the laws of HIPAA and the privacy. So that's a consideration. So you need to be able to provide information that's relevant for care, for emergency preparedness, if you have patients that are maybe staying with you, sheltering in place, and you need to transfer them, etc. And 5 is a means of providing information about your ability as a health center, as an FQHC, to request assistance, and also give out information about your ability to provide assistance if you are able and available to do so. So not only do you need to know how to ask for help, you need to know and describe the process to offer help and how that would take place. So these are the requirements. And now the survey procedures come from the interpretive guidelines that, of course, were released, and you are probably familiar with these. Not to belabor the point, basically whatever is required by the CMS rule, you will need to provide some kind of documentation in the written shape and form so that you do have a written communications plan, that you see the evidence that it's been reviewed on an annual basis, that you do have all of those required contacts and the entities that the CMS wants you to have, and also if you're using primary and backup communications, they may ask to see the equipment that you're using for communicating. If you're saying, well, we have the radios as a backup, well, they may want to see the radios. Also, that you plan includes a method for sharing information, how you'll be providing information about your ability to help, and how you'll be asking for help if that occurs. So those are the survey procedures. So auditors will be asking for pieces of information which would support any of the requirements that were listed and we just reviewed. So let's talk about the general concepts of what you as an FQHC should consider when you're creating this communications plan or including that plan into your integrated emergency management operations plan. That is like a big hefty document. So there are, of course, steps. As everything and anything in emergency management, there is a cycle, right? So we have the 4 stages of emergency management: mitigation, preparedness, response, and recovery, and it goes on and on. The same goes with the communications plan. We talked about the cycle, a similar one last time when we talked about training and testing or conducting exercises. So you need to know what your risks are. It always, any element that you are dealing with the CMS rule goes back to your HVA, hazard vulnerability analysis or risk assessment that you have conducted. What are the most likely hazards to affect your health center, to affect your several and separate locations? So you are communicating in lieu and knowing what those hazards are. So you need to know what the top hazards are, and please refer to part 2 of the series when we were talking about conducting hazard vulnerability analyses and what that means. So you need to know the risks to plan effective communications for those risks. The second step would be to identify your target audiences, who it is that you're communicating with, right? If you think about it, there's many parties that may need to receive your communications. There is, well, the parties were listed, right, in the rule. We just reviewed that. But you may have staff, you may have patients, you may have partners, you may have sister locations and other facilities. You may be a piece in a larger structure. So all of this needs to be considered when you're planning your communication. So you need to identify those entities, who the communications go to. Third is, you need to know what it is that you will be communicating in as much as possible prior to disasters. The reason why we want you to do that is during the disaster, you may not have the ability to sit and design messages. You need to know what you're saying quickly, on point, targeted, knowing who you're speaking with, and preferably pre-identified based on the hazards that you have uncovered in the risk assessment process. Let's think of an example. So let's say in your HVA process, you think that a cybersecurity attack is very likely to happen, right? We're not guaranteed against this. So maybe it carries a very big percentage of risk. So your plan, your communications plan that you're creating or have created should address the fact that you will need to communicate possibly during the cyber attack, and include the messages, how you'll be doing it, considering that hazard, specifically the cyber attack assumes that you may not have access to your systems regularly, right? Will you have the backup to that primary method of communicating, or you may consider a third system that's specific for cybersecurity attack that you may be experiencing. So that's an example. Hope that that makes sense. Designing your key messages for hazards is an important step. And more often than not, we see that that step is skipped because you guys simply don't have time to sit and think of pre-designing messages for various hazards. Now, the fourth step would be to identify the communications methods. Not every key message, will be done and utilized in the same way. You may have key messages which may go in different ways based on who you're communicating with. You may have a message that's the same, but you may use a computer versus a phone versus electronic communications versus a messenger, a person walking towards a facility, for example. So your communications methods need to be pre-identified because your effectiveness would depend on how and who and when you're communicating. Fifth step is to identify the criteria for activating your communications plan and who can activate the plan, including the delegations of authority and the succession planning, which goes back to some of the previous concepts that CMS wants you to do for other core elements, risk assessment and emergency management planning. So you need to know who will be able to activate the plan, how you're activating it, and how you know that the plan is deactivated and no longer is in place. You're back to normal, so to say. So that's an important piece for creating your communications plan. Of course, next step is with any plan that you have, you need to train people on what that plan includes so they know all of the procedures. And of course, you need to test the plan to make sure that the plan is effective. And there's different ways of testing, right? We talked about different types of exercises. Last week, we have discussed the communications drill that took place on the state level. A little bit more about that in a second. We have a functional exercise coming up for New York City-based FQHCs. A lot of you are participating. So that will be a test of the communications protocol. So that's what we mean by this step. And anything that you learn after you do exercises and training and testing, you incorporating into the improvement planning and making your plans more effective based on either real world activations of your plans or exercises and lessons learned. So that's the overview. And of course, you go back to reviewing your risks and making sure that the cycle repeats itself and you're reviewing the components of your communications plan. So that's the structure of what you will be doing overall to create an effective communications plan. If you think about it, the communications plan itself, what is it for? It provides guidance on how you're going to be talking to all of the entities and people who are involved in the work of your health center, how you'll be utilizing the systems, primary and backup communications method, who is the public information officer, who is in charge, who is activating the plan, who is deactivating the plan, who is writing the message, how you're going to maintain the lists, and the plan, the protocols should address all of those issues. Basically, the plan itself will make your communications more effective. And whatever procedure or policy needs to be included to make that happen, that would be a consideration to include in your communications plan. Now, generally, your plans would include some kind of considerations on communications with patients, right? So how you're communicating with your staff during normal business hours or after business hours. Will you use social media or a website or some kind of phone tree or whatever system? How will you be verifying contact information that you have? The information, is it true or not? How often do you check? Well, I apologize, this is about patients, right? So the same goes to staff, and that's the next slide, but with patients, it's kind of the same thing. How will you communicate with people who are hard of hearing, for example? And just generally, what are the considerations for you to create communications that would make sense for the people that you're serving? And of course, it goes back to knowing your population, right? Patient population, and what would be useful, and considering what needs to happen for them to understand everything that you're trying to communicate to them. So all of that is the consideration. Partners. Did I skip? Yes, I think I skipped the staff. But with staff, it kind of is the same idea, right? So you need to know what message would be important for staff to know, and how you're going to be deploying messages for staff during business hours versus non-business hours. You get the drift here. Now, with external partners, it's also a consideration when you're writing your emergency communication plans. Who are you talking to, right? So you need to have a universe of the partnerships. We already have an idea what CMS wants you to have, but they're not providing you with an exhaustive list. So who are other partners that you need to be aware of? Vendors, your neighbors, your transportation companies, your primary care association, aka CHCANYS. Do you know who to call? Do you have a backup contact person? Other community health centers, maybe healthcare entities that are not FQHCs but are in the same sort of domain working with you, maybe a local hospital, local state, federal authorities that are necessary, such as local health departments, FBI, etc. And we'll explain why that is important very, very shortly. You need to know how to verify the contact information at least annually, but a more frequent communications drill is recommended. Also, how will you be notifying your entities, your local authorities, about emergencies that are affecting you, right? So what's the procedure for you based on the hazards? If it is a cybersecurity attack, the list of communications and who to contact may be different than if it was a power failure at your health center and you need to be notifying other entities, versus maybe it's a flood and it's not that huge, so you closed the operations, but you didn't really call anybody. You dealt with it locally, but if you close operations, do you need to notify Department of Health through NIPORTs or not? So these are all the considerations for you to think about when you're writing and creating the communications plan document. Also, generally to consider, who is writing the messages? How will they be different in the coming to an event such as hurricane, right? So what are the messages going to be looking like prior to the hurricane versus during the hurricane as an aftermath, as a recovery piece? So there's that. How will you know what you're saying is correct? Who are you coordinating the message with? If you have messages pre-written, who can pick the messages up and send them, or will there be an authorization needed? Somebody like a medical director or a public information officer or an emergency response coordinator who will authorize the sending of the message and communication, right? Who will determine how it's released, when it's released, what piece of information is withheld, for example. Staff may need to know a little bit more about the information than patients. Staff may need to know that not only are you closing the location for that day, but you're redirecting certain people to a different location. Patients may need to know that this location is closed, but they don't necessarily need to know about all of the staff redirection. They may need to know alternatively about places to go as an alternate if you have location B open that sees them. So all of this becomes very important when you're creating your plans and workflows and considerations for effective communications. Again, goes without saying that every after action report that you read on the local level, such as your own facility-based after action reports after an exercise or a real life emergency, or if you go on a federal level, such as after action reports on like Hurricane Katrina or Sandy, there's inevitably a piece on what the communications could have done better, or there was no communications, or there's inevitably a failure in communication on some level. So this is something to consider and remember. Just think, step outside the box and see what else needs to be put in your plans to make your life easier when it comes to emergencies and discussing, communicating about them. Now, regarding the methods, these are just some examples. It's not an exhaustive list. Of course, there's considerations for you to pick and choose primary versus backup versus one method over another. But think of the methods that may work for you. Somebody may be comfortable using satellite phones, another organization may not be comfortable because it's prohibitive in terms of cost or maintenance, or if you are located right next to, let's say, a police department or fire department, and the facility is walkable distance to those departments, maybe your backup communication method to inform authorities about an emergency is a messenger, a person who physically walks towards that police precinct or a fire department and tells them about the emergency, for the lack of a better way of communicating if you don't have phones anymore. So something to consider, whatever the method is, think of what will work generally, and if that piece doesn't work, how else can you communicate about your needs and the ability to support people? And of course, the messages, the pre-written messages that we already have brought up, have to be delivered in with the delivery method in mind. If you are creating them for social media, think of concise, precise kind of messaging. If you're delivering messages via email, they may be a little bit more elaborate with some links clickable. So you get the idea there. I'm not going to belabor that point. Coordinating the message is an important piece because, again, if you are sending one message, but people are getting another information or another sort of altogether message from local media, everybody is on social media, or they're hearing like Twitter from police department telling them something different than what you are telling your constituents, well, how does that jive with the population of your staff, of your patients, of your partners? So you need to coordinate the message and get the most recent, updated, correct information as possible. And to do that, you need to be able to subscribe and receive all sorts of alerts. So there's a whole universe of alerting systems that exist. There's your CDC, there's the state, local health alert networks, there's the local emergency notification systems. New York City has Notify NYC. New York State has Alert New York. There's all sorts of systems that you should be aware of, and think and pick and choose what works for you so you don't get overwhelmed, but yet you have an idea of what's happening in my community that may be affecting me. So just to keep in mind. You may also get alerts from the local healthcare coalition. You may also get alerts from us, depending on the scope, from CHCANYS, your primary care association. So again, coordinate your messaging and make sure that you get the most recent relevant information there is. And you're not sending the messages to your patients, to your staff, to your command that is not coordinated and giving wrong information. All right, so just like we had the emergency management template, emergency management plan template, we are very happy to announce that very soon, and I can't give you the specific date, but it's almost finished, we will be releasing another template which builds upon the template that you already have, and it will be a template for communications plan. What it creates is just like what I discussed already with you in the beginning of the webinar. So if you right now have the communications plan built into your emergency management plan, this template would allow you to extract that communication piece and have a separate document. So that's what that template is gonna do. So first of all, it's been walked through against CMS rule. So it's CMS emergency preparedness rule compliant. It details some sections and policies and procedures. Whatever I just discussed with you guys, it puts it all on paper and organizes that workflow on paper and addresses the internal, external communication policies and procedures, risk communications, how you develop the messages, how you collect, document, and report information. So this template coming your way very, very shortly. If you're using this template, so what you will do is you will have the general all hazards emergency preparedness plan for your organization. With this one, it will be an annex to your emergency management plan. And that way you have a written CMS compliant written communications plan that you can then take, review, revise, provide to the auditors if need be. So we're very excited about this opportunity to release this, and it's coming your way shortly, so stay tuned. Another piece that I wanted to bring up is if you are a recipient of HRSA Primary Healthcare Digest from Bureau of Primary Healthcare, as recent as October 16th, that's the latest one that included this piece of information. And by the piece of information, I mean the following. I mean this piece. So for the hurricane season, and again, we thought that the season would not be as active, which for New York, fortunately, knock on wood, it hasn't been. But for the rest of the country, as you all know what happened. So HRSA now is paying more attention to emergency preparedness generally. And for hurricane affected states, what they have been asking is that HRSA has asked primary care associations to take lead in gathering critical health center information. So in the past, what happened is that you all have project officers for your HRSA grant, and project officers were reaching out to the health centers, and then that information was somehow going up to HRSA, and then PCA may or may not have been in contact with you, etc. What HRSA wants to do is PCAs will be working with health centers locally to make sure that we know your operational status, your basically are you impacted, what's the scope of the impact, and then HRSA will look to PCA to provide that information up to HRSA. So that's what's happening. And well, that means what? That means that we as your PCA need to be able to communicate with you effectively, and so we know exactly what's happening if you were to be affected by some kind of emergency or disaster. So that means that we need to have information from you. Of course, nothing is perfect in this world, right? So we're not saying that CHCANYS is perfect, but CHCANYS does have an ability to collect information and push information to FQHCs using our internal system called Smart Notice. Some of you have been doing this for a while, probably remember HT Standard. That was supposed to be the answer to our pains, and it wasn't because it was more of a complicated system. Folks didn't remember any login information, and was just not an emergency response system the way it was supposed to be, not to mention that it costs a lot of money. So we moved to Smart Notice system. It's basically a notification system that's internal to CHCANYS, and what we can do is push information your way by email, by phone call, and by SMS text message. So what you see on the screen are the examples actually of what kind of messaging would come your way. The system is a bit primitive in the way of what information we can ask back from you, but there is a simple yes, no kind of questionability and some simple text that we can request from you. And we've been doing it for a while now, trying to clean up our contact information list on our end. But this is why. So if we've been asking for your information and making sure that we have the correct contact info, that's because we are maintaining a list in the background that will be utilized in case of emergencies if we need to contact you and ask for additional information. So stay tuned. Some of you will be participating in a test of the system. All of you will be participating in the test of the system at some point in 2019. We will do an internal CHCANYS only communications drill. And it goes back to maintaining situational awareness and making sure that our communications plan is as effective as we want. So that's all part of communications planning on our end. All right, the elephant in the room, New York State Health Commerce System. I wanted to bring it up because it's an important system, and you all must have an account with Health Commerce System. First of all, because it's full of useful information. Second of all, because you're required to do so. There is a public health law piece that allows Department of Health to demand and require you to utilize this system. So there was a Dear Administrator letter that was sent out to all diagnostic and treatment centers who have an Article 28 license as an outpatient facility in New York State that reminded you why you should all subscribe to this system and why, like they quoted, Department of Health quoted the regulatory authority on how they can require you to use it. So not to belabor the point here, I hope all of those folks on the line who are doing emergency preparedness work for an FQHC have an account. So that account has been utilized on October 9th, unless you're in New York City. New York City was not participating, but it's an important piece for all of us to learn. So that system was triggered to do a state-level, statewide drill. Again, this is part of the communications planning for the state of New York, and that drill showed some gaps. So yesterday, so you guys know, yesterday I had a meeting with the Department of Health, and the purpose of the meeting was to disentangle the many ways the structure, what is being used, because the drill had shown that the tree, the architecture of the system may not be necessarily super perfect. So I want to give you a quick update. So in the state of New York system, HCS, for an FQHC, you guys are grouped under the Diagnostic and Treatment Center, I guess, umbrella, right? For a lack of a better word. So DATC stands for Diagnostic and Treatment Center. There are three types of accounts that an FQHC may have in the health commerce system, and this is where some of the confusion comes in. So you as an organization have an operation certificate, OPCERT. That's one type of an account. HCS also has a PFI kind of an account for what I call a mothership. So your main facility, PFI stands for Physical Facility Identifier or something like that. It's a brick and mortar location that's identified as the main location for an FQHC, for a diagnostic and treatment center. And that account carries kind of like the main role for the whole network. And then under the DATC PFI, there's additional accounts that each other location that's a child location has, and they call it an extension clinic. The reason why I'm telling you all this is because there's more and more evidence that folks come to us saying, well, I didn't receive a notification, I know I have an account, I know I checked and I have all of these roles. It really depends on the type of the account that you're connected to. So again, I don't want to bore you to death with details, but what's happening right now is we're trying to clear out and clean up the structure so we're all on the same page, so the Department of Health knows what PFIs there are, what operation certificates people hold, and what's a child location versus the main location, because you as EM leads at the health center networks on the network level may or may not be responsible for all or some of the emergency management work for the network. So therefore, we're trying to clean up the infrastructure. So, and that becomes important because State Department of Health will be using this for a critical asset survey that's coming up sometime in 2019, which will be triggering HERDS module. They are going to be utilizing the lists that are being cleaned up for another communications drill. There's more talk about how New York City will be participating with New York State, which hasn't been the case. But the good news here, and to finish with this slide, because I'm sure I'm losing some of you in terms of the content, is that there is an understanding that HCS is important, it's not perfect, and we're cleaning this up. So there's that for you. The important piece here is that if you have no idea what I'm talking about, or you don't know or don't remember the last time you logged into the health commerce system, please make sure that you at least know your login and the password and the role. And if you don't know anything about whether you are part of the HCS or not, please give Commerce Accounts Management Unit a call. And they can guide you, they can walk you through the stuff. And when in doubt, let me know. I can actually on my end have a look if you are part of the system and who is your coordinator. So that's going to become more and more important for our ongoing communications purposes. I hope that point is very clear, and I'm sorry if I'm beating the dead horse over and over again in regards to health commerce system. All right, another piece that I think you should be aware of, and it doesn't come very very often, is the Priority Telecommunication Services, or PTS. So the government of the US, of our country, has the specific programs for entities that require priority for communications. There are 4 pieces in this program, and some of you may have heard at least about one of the piece. So there's 4 pieces. This is the GETS program, the WPS program, TSP priority, and the SHARES program. All of them are programs that would allow you to be prioritized in case of emergencies for communications purposes. For example, GETS program would allow you to be prioritized and get through physical phone lines if they are overwhelmed with other people trying to use the physical phone lines in case of emergencies. So that's GETS program. WPS is the Wireless Priority Service, and that program allows you to be prioritized if you're using cell phones. In case of emergencies, cell towers are overwhelmed, and you guys may need to utilize the phones, so that allows you to get priority there. TSP is if your systems are broken for whatever reason, if there's no internet or the power cable got cut by mistake, that would allow you to be prioritized for restoration, TSP, restoring your ability to communicate. And SHARES is a specific radio program. If you're using radio, there's a frequency that will allow you to be prioritized and use that frequency. Now think about some of the implications for your communications planning. It's not an easy program to get into, I'll be frank with you, because it's a federally supported program and it does require some money on behalf of the government. That's why it's not just, oh, everybody sign up. It's more, okay, if you need this, please show us how you're justifying your participation. And you guys, as entities providing critical access to healthcare to the communities, will definitely qualify for at least 1 or 2 of these programs, as has been evidenced by at least one FQHC that I'm aware of who got into the TSP priority program. Now, I'm not saying that you should all run and get the participation, but this is something for you to consider. If you don't have a lot of options in case your internet cable is cut for whatever reason, right? Let's say there's construction and they just sever the cord. What are you gonna do? So this is something to consider. It would require justification from the State Department of Health, and then the review by the federal government. But again, this is something to know. And in the resources slide, you will have a link that you can explore and get information about this. This may change certain things for your communications plan and what you're doing for maintaining that plan. Last but not least is the designation of the public information officer, somebody who would be in charge of sort of like implementing the communications plan the way it's written, maybe approving messages, maybe sending communications, participating in delegation of who is responsible for what. At least the people, your staff should be trained to contact a specific person if they're being approached by media, by, let's say, other entities, and staff should be trained on saying, well, I can't release that information, I'm not aware of it, but this is the contact number for the public information officer. So that is recommended to have for every single FQHC. Another thing to consider to include in your emergency management communication plans are the use of apps. We all use apps on a daily basis, and there's a bonanza of apps that are EM specific, that are free of charge, and that may make your life much easier. So some of them you see on the screen. I'm sure there's many more. This slide, the screen grab is a bit old, but Red Cross has an amazing suite of apps that are free. You can track hurricanes in real time. You can mark yourself safe. There's, see floods, pet first aid, etc. Then there's the FEMA, My Radar, and a lot more. Again, not gonna go too much into detail because it kind of goes without saying, but consider using this as your part of the communications planning. All right, so let's see. Our next slide is about coalitions. You should all know what your coalition region is as an FQHC. If you are in New York City, you are in the New York City Healthcare Coalition. If you are outside of New York City, you may belong to one of the 5 regional health emergency preparedness coalitions. I would highly encourage you to know at least the contacts and be on their mailing lists. If you need support in knowing who to talk to, what meetings there are to attend, please let me know. CHCANYS is your representative for Healthcare Coalition, sort of like liaison, but again, there's 6 entities and there's only so many of me to attend all of the meetings. So we try to do our best, but if you want to attend those meetings regionally, let me know. And I think a lot of people do attend, and they find them quite helpful. There's been a tendency to not only talk about hospitals in these meetings, as was the case before. Now people are much more inclusive of other partnerships, such as home health care, FQHCs, community outpatient clinics, etc. So let me know. All right. And this, again, I'm not going to speak too much, but think of the list of the partners that would be useful for you in case of emergencies, and do have that contact list handy whenever you have your planning. So maybe include it as an extension of your communications plan. Just some thoughts and ideas of who you should be aware of as a New York State, New York City FQHC. Again, you'll have this list available in your slides. And I want to point out 2 specific hazards that may affect your FQHC, and we haven't really spent too much time talking about these hazards. The first one is the cybersecurity hazard. We have recently had a health center affected by this, and my concern as an EM person is always, do folks know who to contact? Yes, you can't access your records, but do you know who to call? Because there's a whole bunch of people that you should be calling. Greater New York Hospital Association is a good friend of ours as a program, emergency management program at Greater New York is our friend. And they have shared a lot of resources with us that are relevant and applicable to you as well as community health centers. So Greater New York has separated, and that's actually the screen grab that you see on the slide as an example. So they separated the contacts and what you could do in 3 stages: preparing, responding, and recovering, such as emergency management cycles. And in preparing, for example, they are suggesting that you have contact for Department of Homeland Security, US CERT program, and I don't remember what it stands for, but US CERT program is very good for preparing, being alerted to what's out there, what risks there are. Law enforcement agencies, FBI, police, do you know who to call? Do you know their specific numbers for those divisions? Maybe us, if you are being affected. So that's a consideration. Responding, right? So not only do you need to contact the police, there's other entities, FBI, FDA if the medical devices were affected. There's the Office of Civil Rights, HIPAA, where patient private information stolen. I mean, there's a whole bunch of considerations there. Again, if you are interested, please let me know, and I will send you this guide that comes from Greater New York that includes very detailed information on what to do. So that's something for you to consider and include in your communications planning. Now, unfortunately, since the last time we had this crazy Pittsburgh event with an active shooter situation, and this is more of a concern for a lot of folks. If you think about it, communicating during an active shooter event may augment certain things that you do regularly for your emergency preparedness. Active shooter communication, it may be very, very different from your hurricane preparedness communications, right? So to that, I'd like to recommend this specific resource called Active Shooter Planning and Response. Learn how to survive a shooting event in a healthcare setting. This document was updated as its third edition in 2017, which is very, very recent. In it, there's a whole bunch of it's more than 100 pages long for a good reason. It discusses in detail what you should do generally as a healthcare entity to prepare for an active shooter event, including the communications considerations. And last but not least, they do have sample policies and procedures, sample language, as an example of what your policies and procedures should look like in terms of responding as well, who to call, how to contact them, and what should be considered. I decided to bring it in lieu of the events that just took place, and communications, again, are an important piece with the active shooter threat, and they are somewhat different, including using of codes and how not to use codes for active shooter. Please download, have a look. It's a very useful piece of information for you. Again, the link will take you directly to the FBI page where you can download this and read it online. All right. Are there any questions before we switch gears a little bit and go into the integrated health planning? And while you're thinking about the questions, I'd like to ask a poll about your communications plan. So currently, as we speak, is your communications plan integrated into an all hazards emergency management plan, or you do have a separate written document that is a separate communications plan? And the answers are integrated, it's separate, we don't have a written communications plan, or I'm not sure and I can't answer that question. So take a few seconds to respond. I would really appreciate folks responding. Again, is your plan, communications plan, integrated, separate, we don't have one, or I'm still not sure at this specific time? So I'm going to give you guys a few more seconds to respond. Thank you to all those who are responding. All right, 10 seconds left. Thank you very much. All right. Okay, I'm going to end the poll now. Thank you all for participating. And here are the results. So you see the results on your screen. So the majority of you, and this is not a big sample, but in the majority, 55% who responded, have it integrated into a plan. And that was my kind of feeling. So that is why we're introducing another option, right? So this template for communications plan would allow you to separate, not necessarily take them out of context, but separate the communications plan as a separate document, which becomes an extension of your integrated plan. And you may choose to base your program that way. Again, one is not required over another. CMS gives you considerations or flexibility to build it any which way you want, but this is good to know. So hopefully this new way of doing the communications plan well, you may find it useful. Okay, thank you very much. All right, now let's switch gears a little bit and talk about the integrated health systems, right? So integrated health systems is not a required element. It's an optional element, and it was introduced into the CMS final rule after the whole lot of comments came in and folks felt like CMS wasn't giving them enough room to consider that you may have different locations, but your emergency preparedness plan and program address multiple facilities at the same time, which is probably the case for a lot of you. You have one program, one set of policies, one training and testing program that would be applicable to a whole lot of locations under one umbrella. Now, this element allows you to do that, but there are some requirements. If you choose to use this element, which I actually highly recommend for everybody to use to make your life easier, But if you choose to use this element, there are some requirements to make sure that you meet the CMS rule. Now, you need to demonstrate that each separately certified facility that's subject to an audit by CMS has actively participated in the development of the unified program. Well, before even that, the facility needs to choose to participate in the integrated program, right? So first of all, you have, let's say, 5 locations. All 5 locations need to demonstrate that they chose to participate in the integrated program, and then that they each participated in the creation of the program, and that the program itself was developed considering the individual characteristics of each facility participating in the integrated program, and that each separately certified facility can meet CMS requirements by actively using the program. So to say that it's not the mothership sending the plan to the facilities and the facilities all of a sudden need to comply without the plan being very meaningful to them. So that's points 1, 2, and 3. And point 4 tells us that the plan, the integrated plan, must be based and unified based on the all hazards planning, including community-based risk assessment, facility individual-based risk assessment for all of the facilities that are participating in the integrated program, and that the set of integrated policies and procedures, integrated coordinated communications plan, integrated training and testing programs do meet the requirements of the general program that is in question. That is the general CMS requirement. So basically, to make things simpler is, if you're using the integrated program, can facilities use it meaningfully? Did they participate in creation? And can facilities meet individual requirements by CMS using the integrated program if they were to be looked at as individual facilities? All right, survey procedures, they would want to see what that is, ask for documentation, how the facilities participated in the creation of this program. They would want to see the integrated plan, what that means, ask leadership of how the plan was created and integrated, how you coordinated the participation of everybody in creating and writing this plan. And if we look at the structure of the template that, again, we have provided to you guys, there's 2 sections here that would become important where you can document your integrated health program approach. The first one is in the program administration, where you basically will write, we as an organization have chosen to utilize an integrated health program when it comes to emergency preparedness, and the following facilities have chosen to participate in the program, et cetera, et cetera, et cetera. And when you are talking about plan development and maintenance, which is part 9 here, you would describe how the plan is developed. We get together with representation from each facility. We review it yearly with representation from each facility, and they get to vote on it, or I don't know what system you'd use, but that's where you would describe how your program is developed. Now, some tips, and this has been included in the updated template. In section 1.1 of our current template, you can use the following language. As you see on your screen, Unified EM Plan has been developed by, let's say, FQHC Network with the active involvement of each of its facilities. In the scope, you may list each separately certified facility, describe how they all participated, etc. And some tips for you generally. All hazards approach is important when you're doing the emergency preparedness program. Command is important, right? Emergency planning is ongoing, it never stops, and you all know about this. Effective training and testing program is important. Ongoing monitoring of all alerts and emergency preparedness procedures, effective communications are important. Document, 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 right? If you didn't document, that didn't happen. So some tips for you. Again, I don't want to go too much into this. You already know this. And I want to describe some resources for you. So as always, with communication planning, with integrated healthcare systems planning, the resources that you see on the screen do come very handy. They contain updated information, something that you need to be aware of on the CMS level, on the certification level, on as per Tracy level, etc. These are some tips, some websites, forgot the word, that you can use to go in reviewing the concepts of emergency preparedness planning, as we talked about. Emergency Communications DHS is where you would get more information on the priority planning. The GETS program, WPS program. Disclosures, this is for HIPAA and HIPAA planning on what to disclose, what's not to disclose. In fact, this list, the address at HHS, Health and Human Services, contains a whole lot of information on HIPAA and how it's applicable during emergency situations. And as always, guys, of course, the time is not necessarily, well, we can't teach you everything over an hour, hour and a half of the webinar. So if you are ever in doubt or have anything of a specific resource need, such as, oh, I don't know who my local FBI field officer is, let me know, let us know. Again, we'll keep you posted on any updates and what's coming your way. And with that, I will leave some time for questions. When we finish the webinar, you will be taken to the evaluation page. It will take you 2 minutes, if not 3, to answer a couple of questions about the series. Hope the series is useful, but we would really appreciate you guys providing us with feedback via SurveyMonkey. The webinar is also being recorded, so the slides, of course, will be available to you tomorrow after 24 hours. They will be sent to you by Zoom, but we will be posting also the video recordings on our website. And of course, you'll have access to that as well. Now, are there any questions? You can submit them via chat or via Q&A module. So feel free to use one or the other. And if there aren't any, that concludes the webinar content. I hope it was helpful. And because it's our last webinar in the 4-week series, it's been a pleasure to give you updates on some of the important things. I'm sure we'll see all of you in one shape or another, in one event or another throughout the upcoming year and their activities. I know that some of you have been in touch with me, so thank you very much. Don't hesitate. And I don't see any questions. So thank you all for your time. And that concludes our webinar. So have a wonderful day and have, I hope you had a great Halloween yesterday. And there is almost just a little bit left for the weekend. So hope you have a great time, guys. All right. With that, we are signing off. Have a wonderful day all.